Hi, everybody. Welcome to session number 255, the use of Thyrogen versus T4 withdrawal to prepare for radioactive iodine treatment or scans and or for stimulated thyroglobulin testing with or without scans. And it is my true pleasure to introduce Dr. Sarimar Agosto Salgado. Dr. Salgado is an oncologic endocrinologist at Moffitt Cancer Center in Tampa, Florida. Her clinical interest centers on the management of thyroid nodules and all stages and types of thyroid cancer, including administration of systemic therapies for aggressive tumors. Her research interest focuses on intermediate high-risk thyroid cancers in terms of management, surveillance protocols, targeted therapies, and potential redifferentiation of tumors resistant to radioactive iodine. My name is Daria Gerald, and I'm here just to help with passing along questions, which we will do after Dr. Salgado's presentation, and I'll turn it over to the doctor. Thank you for being here.
Thank you for your kind introduction and to the ThyCa organization for the opportunity. It's really an honor to be here again. And moving forward with this very important and relevant subject for patients with differentiated thyroid cancer. These are my disclosures. And the objectives of this presentation is to understand the different preparation modalities and indications for radioactive iodine administration, review the risk and benefits of each modality of preparation, possible indications of whole body scanning in terms of surveillance, and some perspectives on the possibility of redifferentiation therapy and preparation for that therapy. And as a form of background, especially for those that are at an earlier stage of disease, the general preoperative workup for thyroid cancer includes a comprehensive ultrasound that will evaluate all the cervical lymph node levels in the neck, as although lymph nodes are part of our immune system, given the proximity of them at both sides where the thyroid is, it's really the most common place where thyroid cancer can spread to. There are certain scenarios, especially if there are large thyroid nodules, that before surgery, your treatment care team might even need to consider a CT scan of the neck and the chest. It is recommended to have a voice assessment or evaluation of the vocal cords, evaluating the thyroid function test with blood work, and a biopsy to clarify whether a nodule is malignant or not. Sometimes also lymph nodes may need to be biopsied, depending on how they appear on an ultrasound or imaging. And we have what we call the Bethesda system classification to reporting the result of a biopsy. And sometimes a biopsy can be clear-cut in telling us if a nodule it's benign or if it's a thyroid cancer. But sometimes before surgery, the biopsy is not completely clear and it comes back at an indeterminate result, which is usually what we call either a TP of uncertain significance or follicular neoplasms, which have between 22 to 30% chance of a malignancy. And in the former days, we used to repeat another biopsy, and depending on the results, if it was still inconclusive, patients would go to have a diagnostic surgery. But nowadays, in the era of what we call molecular testing, we can do special tests to try to identify potential cancer drivers or changes at a more genetic level in the tumor cells or in the nodule cells to really identify if we have a thyroid cancer. And depending on the nodule size, that molecular testing, and if there's a presence or absence of lymph nodes, determining the extent of whether a partial thyroid surgery or a total thyroid surgery is indicated. Most of the times, the patients that end up having surgery are those that either have large thyroid nodules that are causing symptoms in terms of neck pressure or swallowing problems, as well as patients that were diagnosed with thyroid cancer or that had an indeterminate biopsy, and the molecular testing led to concerns of a malignancy. Once thyroid is removed, if a partial thyroid surgery is undertaken, we have seen that the other side of the thyroid or lobe is not able to compensate completely for the functioning 30 to 50% of patients, and those patients need to be on thyroid hormone supplementation despite still having part of the thyroid in the neck. But when the whole thyroid is removed, there is a need to be on lifelong thyroid hormone therapy, which most commonly is in the form of levothyroxine. And some patients may need to have a second form of thyroid hormone added if there are persistent symptoms of hypothyroidism that are not controlled only on levothyroxine. We see that normally the pituitary gland, which is a master gland in the brain, releases thyroid stimulating hormone, or TSH. And you might recognize that from blood work that your physician does periodically. Because after surgery, we utilize that marker to let us know if your thyroid dose medication is appropriately. In fact, in differentiated thyroid cancer, which includes papillary and follicular thyroid cancer, for example, we many times need to give a slightly higher dose of levothyroxine than what your body needs to keep those TSH levels on the lower end, as that has an anti-cancer effect and is part of the cancer treatment. And after somebody undergoes thyroidectomy, and I'm going to focus now more on patients that have total thyroidectomy, we evaluate several things. We look at what we call the pathology report, which is basically telling us what the size of the cancer was, what were the characteristics when the pathologist looks at the tumor under the microscope, and that allows us to estimate what are the chances of the coming back and tells us as physicians if we need to do anything more. In addition, there is a protein called thyroglobulin, which is produced both by normal thyroid tissue and from papillary and follicular thyroid cancer cells, and that protein is called thyroglobulin. And after somebody has had surgery, usually around 4 to 6 weeks afterwards, we look at that postoperative thyroglobulin, and that also gives us some information about what the status is post-surgery. And based on the risk of recurrence and the thyroglobulin levels and individualized factors, we utilize selectively radioactive iodine. Radioactive iodine is utilized in differentiated thyroid cancer because the cancer cells, similarly to normal thyroid cells, have some gates that are able to bring into the cell iodine. So we take that to our advantage and prepare patients for this treatment in a special way, which we will discuss in this presentation. As I mentioned, also keeping the thyroid hormone levels well under control is also an essential part of the treatment for differentiated thyroid cancer. And the American Thyroid Association has developed a risk stratification for recurrence based on characteristics like the tumor size, how many lymph nodes were involved, and if the tumors were trying to extend out of the thyroid or trying to extend out of the lymph nodes. And based on those characteristics that we obtain on the surgical pathology report, we can classify if there is a low, intermediate, or high risk of recurrence. When there is a low risk of recurrence, the evidence has shown that the long-term outcomes are similar if you administer an ablation dose or a low dose of radioactive iodine versus if you do not administer radioactive iodine. So more and more, we do not administer radioactive iodine in patients that have a low risk for recurrence, except in very specific circumstances. We might consider what we call an ablation dose, which is a low dose mostly to eliminate if there's any residual normal thyroid tissue and follow tumor markers more reliably. Although in my personal practice as an oncologic endocrinologist, I'm very comfortable following low-risk patients without having to do an ablation dose of radioactive iodine. But when we start seeing that there's more than 5 lymph nodes, we start seeing an intermediate risk of recurrence. And in that scenario, it is important to consider radioactive iodine, obviously putting the patient in the center, their age, comorbidities, and that post-operative status, as I mentioned, looking at that thyroglobulin markers. We do know that for cases that the tumors are large or trying to extend out of the thyroid, or when there's presence of concerns for distant metastatic disease, or a significant amount of large lymph nodes involved, definitely radioactive iodine is recommended. And the higher the risk of the recurrence, the lower we want to keep that TSH. So I'm going to go ahead and start with a case to kind of put us in the context of a more low-risk thyroid cancer. So I had a 62-year-old lovely woman with multiple thyroid nodules that were incidentally found in a carotid Doppler ultrasound. She had some comorbidities, including high blood pressure, diabetes, cholesterol issues, and had been noticing some intermittent discomfort swallowing with solid foods, mostly bread, and her pills for some time. And doing a dedicated imaging of her thyroid actually showed that there was a left large thyroid nodule around 5 centimeters, as well as a contralateral smaller lymph node in which actually the smaller lymph node had some irregular borders and some calcifications, some more high-risk features than the actual larger nodule. So she ended up having a biopsy of both thyroid nodules, and both biopsies came back on that indeterminate category. So there was additional molecular testing that was leading us to think that the larger nodule was a benign tumor, but the smaller tumor had a 50% chance of malignancy based on the molecular testing, and based on that, she proceeded to have a total thyroidectomy. And the final pathology confirmed that the larger tumor was actually benign, but that smaller tumor was a 1.9 centimeter papillary thyroid cancer that was pretty well contained, very good margins, not trying to extend out. So it was a stage 1 cancer that, based on the ATA guidelines from 2015, the risk of recurrence was quite low, between 1 to 2%. The thyroglobulin levels were not very elevated. There was no antibodies present, and we had a good conversation based on the evidence, and she felt comfortable with just observing without radioactive iodine and neck ultrasounds and monitoring the thyroglobulin, as the radioactive iodine remnant ablation, or that low dose of radioactive iodine, is not routinely recommended for these population. Now, in other settings, where we start thinking about more intermediate and higher risk thyroid cancers, we start talking about radioactive iodine consideration. And how do we prepare patients to receive radioactive iodine? So we have to make the body intentionally hypothyroid and follow the low iodine diet, sort of to make the body and if there's any remnant cancer cell, hungry for iodine, so that when the treatment is administered, that it goes and functions the way we want it to. So traditionally, the first way that was available to prepare patients was actually stopping the thyroid hormone for around 4 to 6 weeks, which we're going to call thyroid hormone withdrawal. But more recently, there's been the availability of an injection that many of you may know by the brand name Thyrogen, but it is recombinant thyroid stimulating hormone, which is basically an injection that is administered on 2 consecutive days before receiving radioactive iodine. Once a patient is hypothyroid by either of these 2 ways of preparation, we check those thyroglobulin levels, what we call stimulated, basically to see how high that marker goes under stimulation. It's very important to make sure that women in reproductive age are not pregnant before receiving the radioactive iodine. And it's actually something that I incorporate in the discussion before even setting up the radioactive iodine, because it is recommended to avoid radioactive iodine for a certain period of time after being treated. I usually recommend a year after therapy. And actually in my institution, in addition to that, and many of the institutions in the US may consider doing a pre-therapy iodine whole body scan, which is basically that during that period before receiving the radioactive iodine, they administer a trace or dose of iodine to evaluate if there's any other uptake beyond the neck, and kind of estimate the percentage of uptake in the neck. And that is valuable because if as physicians we're planning for a dose, but the pre-therapy whole body scan tells us that we need to escalate that dose if there's more disease than we anticipated, it's an opportunity to adjust the treatment. After the radioactive iodine dose, which is an oral medication, it's administered, it is recommended that patients are isolated to avoid exposing others to radiation, and that time frame may vary depending on the dose that it's administered. Some patients will be able to isolate safely as outpatient or in their homes, but if there's any specific scenarios or regulations, some patients may need to be admitted in the hospital for isolation. And still after going the treatment, there's importance to, as you can see on the graph on the right corner, that there's some precautions, including making sure you do keep your records that you were treated with radioactive iodine, avoid traveling by public transportation also for a certain period of time. And I always make a point to emphasize to all my patients that it's very important not to miss the appointment of the post-therapy whole body scan, which is done between 3 to 7 days after the radioactive iodine is administered, to really see what were the areas that had activity. We tend to see usually some activity in the neck, and obviously activity in the areas that are clearing out the radioactive iodine from your body. But if there's any other areas that a radioactive iodine shouldn't be there, it's important for us then as doctors to follow up on evaluating that further. Now, the process of preparation by levothyroxine withdrawal or stopping the thyroid hormone medication is usually by holding the thyroid medication, usually at least 3 to 4 weeks before the therapy or any diagnostic whole body scans. If it is going to be a period of 4 or more weeks, you can give a shorter form of thyroid hormone, which is liothyronine or T3 cytomel, to kind of prevent from feeling that hypothyroid symptoms for some time. It's very important to look at the TSH levels before administering the radioactive iodine, and the usual consensus has been that the TSH should be above 30 to be able to proceed with either diagnostic testing or radioactive iodine. But what happens and why sometimes we pause on selecting this approach is that during that period of not being on the thyroid hormone medication, even if we administer cytomels, patients may experience the symptoms of feeling hypothyroid. And some of the symptoms might be mild, including cold intolerance, some drier skin, but there could be some more severe side effects, including mood changes, exacerbation of depression, decrease in the heart rate, significant fatigue or difficulty concentrating. Patients that some patients might actually experience electrolyte imbalances, including, for example, the sodium going low, and I have seen that being sometimes a significant barrier to using this approach. And if somebody is also profoundly hypothyroid for some time, sometimes we can even see a little bit of fluid build up around the heart. So it's definitely something to be cautious if we're having somebody that's a risk of cardiac complications. And in reality, obviously, there's none of the symptoms of hypothyroidism that should be minimized. And that is why it's always important to balance both options. When we use the recombinant TSH injections or Thyrogen injections, as I mentioned, they are administered on 2 consecutive days. And on the 3rd day, patients receive the treatment for radioactive iodine, followed by that whole body scan. But obviously, as any medication, anything could have certain side effects. And although in my clinical practice, the Thyrogen injections have been very well tolerated by my patients, I personally have not seen a severe reaction or side effect to them. I still wanted you to have the information of what has been reported out there, including some of the information from the company that makes these injections. And some patients may experience nausea, headache, fatigue, but as you can see, the percentage of that is not very elevated. And if we think about side effects like vomiting or dizziness, those are even fairly lower and around only 2% of the cases. Some of the things that we do balance and consider is that if there's any significant thyroid tissue remaining or distant metastasis that could be functioning or trying to produce hormone, there could be a transient episode of hyperthyroidism after radioactive iodine ablation. I personally have not seen this, but it's definitely something to be cautious and monitor closely. And depending on the tumor location, if there's any tumor remaining, sometimes your physician may consider premedicating with steroids if there's any concern that any transient minor swelling during this preparation could cause any side effects. Moving forward with another case, we have a 42-year-old woman that self-noted a neck lump as she was applying makeup, and ultrasound and biopsy led to concerns of papillary thyroid carcinoma, which was confirmed after the total thyroidectomy, revealing that the cells also had what we call tau cell features, meaning that around 30% of the tumor, when it was looked under the microscope, the cells looked slightly taller than what they should be, and there were more than 5 lymph nodes involved, so putting her at an intermediate risk of recurrence of around 20%. It is still considered stage 1 as in differentiated thyroid cancer. We divide the staging system based on age above or less than 55. So less than 55 years old, if the tumor is only confined to the thyroid and only involving neck lymph nodes, it is considered stage 1. If it has spread beyond the neck lymph nodes, that's when it's considered stage 2. And because of that intermediate risk of recurrence, I went ahead and had also the patient undergo a CT chest non-contrast that didn't have any lung nodules or any visible skeletal metastasis. And we were in that discussion, do we administer radioactive iodine? She's on that intermediate risk category where it can be considered. And we had, she was not planning in having any future children in the near future. We looked at her thyroglobulin levels, and going back to what the guidelines say in terms of preparation, we have seen that in patients with low risk and intermediate risk that don't have extensive lymph node involvement, in which we're considering radioactive iodine therapy after what we call an ablation, which is usually a lower dose, versus adjuvant therapy, which is usually a higher dose when we're talking more than 50, 75 millicuries. Then we say that it is, the guidelines say that it is acceptable alternative to use Thyrogen versus the thyroid hormone withdrawal, based on evidence of quality of life and data that shows that using the Thyrogen has not been inferior in terms of efficacy, and consistent observations on follow-up studies. In patients that have intermediate risk thyroid cancer that have extensive lymph node metastasis, but that the cancer has not spread beyond the neck, it may be considered using Thyrogen as a form of stimulation before iodine, but they're not recommending necessarily that as a very strong recommendation. They put it more as a consideration, and it's because however, these type of studies will need to be multi-institutional. They will require a lot of funding, and because of a lot of variability in practice and individual I think that is that we're going to get. In addition, you might see that many of Thyrogen as a form of preparation. I have practiced at multiple centers and have felt very comfortable using recombinant TSHs are quite similar. So I do consider it for my patients that this form of therapy. Now, our patient went ahead and had Thyrogen stimulated radioactive iodine, and as you can see on the post-treatment scan, she had the neck uptake as expected. Now, following with a more higher risk case, I have the case of Mrs. Jones, and again, this is a hypothetical name to protect her patient's identity. But she presented with a 4-centimeter thyroid nodule, and we could see on her ultrasound already some lateral lymph nodes that look solid. Usually lymph nodes in an ultrasound should look more flattened and have a fatty center that we call a fatty hilum, but we could see on the ultrasound that some of her lymph nodes looked completely solid, which is why she had a preoperatively not only thyroid biopsy but also biopsy of her lymph nodes, and that led to having a total thyroidectomy with central neck dissection and what we call a lateral neck dissection, meaning removing lymph nodes on the lateral side of the neck. And the pathology showed a 4-centimeter papillary thyroid carcinoma that was trying to extend outside the thyroid. It was extending to multiple lymph nodes, both at the area that's below the thyroid, which we call level 6, and also on the lateral sides of the neck. And there were a total of 13 lymph nodes, with some of those lymph nodes also showing that the tumor was trying to extend out of the nodes. And that raises the risk of recurrence to 40%. And she had a postoperative thyroglobulin of around 2021. So when she came to me for an oncologic endocrinology consult, I went ahead and did some additional staging imaging and found that she had some small sub-centimeter long nodules that I highly suspected that were related to thyroid cancer based on her thyroglobulin and the appearance. And she had mentioned that briefly after her surgery, there was a short period where she wasn't taking her thyroid hormone consistently and had not been feeling well, with a lot of brain fog and fatigue. And even now, taking her thyroid medication constantly, that was an issue. So she knew she needed radioactive iodine, but she had some concerns about being hypothyroid for so many weeks, especially in the setting of being a very busy mom. So we had a good heart-to-heart conversation, baseline based on my evidence in clinical practice, but also with the data that has been published by wonderful colleagues all around the world. And she felt comfortable proceeding with radioactive iodine with Thyrogen injections. She received 200 millicurie. And as you can see, there was some long uptake. We've been following her with pulmonary function tests and imaging, and she did not have any complications from the radioactive iodine, and it's actually doing quite well. So the American Thyroid Association has taken a position in this type of scenario of high-risk differentiated thyroid cancer, and has mentioned that in patients that have higher risk of recurrence, ideally we would need more control data before the recombinant TSH. Recombinant TSH injections are strongly recommended for preparation. So it mostly ends up being, like in my case, a patient and physician conversation, and taking into account the whole picture of the patient that I have in front. But they do make a very important comment that at any level of risk, whether low, intermediate, or high, if there are other medical conditions or what we call comorbidities that would limit us from safely doing thyroid hormone withdrawal, then thyrogen preparations should be considered. And some of those comorbidities may include things that are physical, like any cardiac issues, as I mentioned, electrolyte imbalance, but also it can include mental health or psychiatric conditions that could be exacerbated if there's a prolonged period of hypothyroidism. And in those cases, it's a medical decision to consider the recombinant TSH injections for safety. And as I mentioned, many of the large medical centers, basically all of the places that I have practiced, we have utilized Thyrogen injections in high-risk patients. And why is that? Well, I wanted to bring you some of the information that has been more published in the more recent years. This was a beautiful study by our Italian colleagues, where they went back and looked at their experience actually over 15 years, and found almost a similar amount of patients that had been treated with either the Thyrogen injections or rTSH, as you can see, versus the group that had thyroid hormone withdrawal, which they call the hypo group. And they made a very careful analysis and had patients that had basically very similar characteristics in terms of age, the type of cancer, and extent, and they were able to match those cases quite nicely, as well as based on the risk stratification that we have discussed so far. And what they found was that the outcome was very similar when they follow up patients for about 4 years. They actually found that in the setting of metastatic disease, the potentially curative or remission responses that were seen was similar to what had been reported in the literature regarding either in either of these preparations. And the 91% of those patients had what we call a clinical benefit, which is that either the tumors slowed in terms of their growth, or they remain stable. And so based on those outcomes, there was really no impact on the efficacy of radioactive iodine, whether either preparation was elected. In fact, in terms of the how what we call the structural disease or the tumors that were still left, whether in the lungs or the bones, were remaining, the data looked that the responses was quite similar. Here on the graph on the right, you might see that on the recombinant TSH group, which is the white bars, there might have been a slightly higher percent, but when they looked at the analysis, the reason was that actually some of the patients that were treated with Thyrogen had pre-existing, meaning they had for more bone radioactive iodine. So mostly what we see is at least some stability. But when they did a careful analysis, there was really not a true significant difference between either of those preparations. But I didn't want you to stay only with one study and my clinical experience as a guide. You can see here that more recently in 2022, on some guidelines of patient preparation for radioactive iodine, the UK has taken a very similar position as the American Thyroid Association, in which they do mention that recombinant TSH injections or Thyrogen injections can be used before radioactive iodine therapy if there are metastatic disease or a local regional recurrence. Obviously, being careful, as I mentioned, if there's any concerns of a tumor flare or some swelling, that your doctor would treat you potentially for that indication with steroids. And so they do consider also for patients that, as you can see, are also on the intermediate risk. And in the US, there have been also some retrospective studies that have also supported this practice. This is another study that they were able to match patients and that had received either of the preparations. And similar to what has been shown, as I mentioned, in the lower risk thyroid cancers, that the mode of preparation for radioactive iodine, whether Thyrogen or thyroid hormone withdrawal, did not affect the overall survival or the time to progression, recurrences, etc. So you can see that this is data from different centers, not only in the US, but also you have seen here information from outside the US. And more recently in 2023, there was actually what we call a review study, where these investigators basically went back to look at data of 10 studies that looked at radioactive iodine preparation with either of these modalities. And they actually concluded that the cumulative data of all of those studies didn't show that there was an effect on the effectiveness of radioactive iodine if you use Thyrogen, and that basically the choice of therapy should be deferred to the clinical evaluation, meaning that patient-physician conversation and taking into account your specific scenario. Now, thinking about the surveillance, really, when do we do routine monitoring with a diagnostic whole body scan? In the older days, the guidelines would incorporate more and more the whole body scans, but now we focus a lot on what we call the response. The response is meaning at how the disease has behaved after surgery or after radioactive iodine. And there is the category that is where I would love to see all my patients, which is what we call excellent response, which is that we're not seeing any evidence of tumor, whether we are seeing basically negative ultrasounds, or there was no evidence of tumor by diagnostic whole body scan, or we see low thyroglobulin levels when patients are taking the higher dose of the levothyroxine, which is TSH suppression, or if we do a stimulated thyroglobulin, it does not go above 1. So in this scenario of taking into account the excellent response, the American Thyroid Association has said if you have a patient that has a low risk or intermediate risk who had remnant ablation or adjuvant therapy or higher doses of radioactive iodine, and you're having a negative ultrasound, you can measure the thyroglobulin and use the ultrasounds basically to monitor, but repeat stimulated thyroglobulin testing is not really recommended for low or intermediate risk patients if you're seeing an excellent response to therapy. Now, you can consider subsequent TSH-stimulated thyroglobulin testing if you're seeing basically that there is an indeterminate response, whether you have antibodies that are still present or non-specific findings on an ultrasound, you're seeing rising tumor markers, or you're seeing still disease, then you can consider in that scenario to evaluate if there's still a role for radioactive iodine. So after the first post-treatment whole body scan following radioactive iodine ablation, patients that are low risk or intermediate risk that have that excellent response of a non-detectable thyroglobulin and negative antibodies, as I mentioned, you can follow with ultrasound, and they do not require the whole body scan. But you can certainly consider incorporating a diagnostic whole body scan by either by withdrawal or with Thyrogen 6 to 12 months after radioactive iodine in patients that are at high or intermediate risk that have persistent disease. Now, I want to make a very pause here and a word of caution that individualizing you and putting you in the center is always key. Please do not question why necessarily your doctor hasn't done a whole body scan, because your doctor might be seeing a bigger picture if your tumor markers are going down, or if they're seeing an overall favorable response so far, or had concerns of giving more radioactive iodine, then they might elect to follow your case with different imaging modalities. And also, if there's a rising tumor markers, personally as an oncologic endocrinologist, before resorting directly to going to a whole body scan, I like to try to investigate where that thyroglobulin is coming from to try to detect if there is what we call any structural disease, meaning any tumors, whether they're in the neck or outside the neck, that I can see and treat to really determine, is radioactive iodine the best option? Because nowadays, more and more, we are very selective with the dose of radioactive iodine that we give, because there are some criteria of what we call RAI refractory, or meaning tumors that do not respond anymore to radioactive iodine. And as I said, going back to those responses, a lot of the times when patients are early diagnosed, they're highly focused on the staging. And more as physicians, we actually focus more on what we call the response. The response to therapy is looking, as I said, at the imaging findings, the thyroglobulin levels, and you can see that sometimes, even if there is rising tumor markers, or the tumor markers have stayed stable, or those antibodies have stayed stable or are not declining, still what we call the disease-specific death, or the risk of dying from thyroid cancer, remains low. I work a lot with patients that have what we call a structural incomplete response, which are patients that I see that there are still active tumors that require either very close active monitoring on their thyroid hormone suppression or TSH suppression, or patients that might need additional therapies. In this slide, I wanted to and especially for those that still have some disease present and that might be questioned, do I need more radioactive iodine, or those that have been classified as having tumors resistant to radioactive iodine. We have here a thyroid cancer tumor cells, and if we think of thyroid cancer being driven by an internal chain of signals that keeps telling that cell to grow and multiply, more and more the world in oncology has been evolving towards trying to identify what are those key signals or drivers that make thyroid cancer grow and continue progressing. And we have seen that in differentiated thyroid cancer, the most common alterations are actually BRAF alterations, followed by RAS alterations, where you can see here in the mid part of the graph. But some patients that might have had a prior radiation exposure, or especially younger patients, may also have what we call fusions or gene rearrangements in either the RET or NTRK gene. So as an oncologic endocrinologist, I know this slide is busy, but I always say that I want to see that it keeps getting busier with more and more drug therapies. As you can see, those are the names that are listed outside the cell until one day we can have hopefully a cure for all stages and types for thyroid cancer. Now, we had mentioned that thyroid cancer cells, and the reason that we treated especially with radioactive iodine early on in disease, is because of these gate channels that are, we see over here in the lower part, called the NIS, or sodium iodine importer channels, that allow the radioactive iodine, or I-131, to go into that thyroid cancer cell and to destroy it. Over time, what happens is that the thyroid cancer sort of outsmarts its way a way to survive, and basically doesn't allow the iodine to come and eliminate those cells. But we have seen in something that is called redifferentiation, that sometimes after, depending on the specific alteration that is found on molecular testing, we can sensitize some tumors back again to be able to have that reactivity to radioactive iodine. So, for example, there have been studies of utilizing the BRAF and trametinib in BRAF mutated tumors, or using a MEK inhibitor like trametinib in RAS altered tumors to try to differentiate or resensitize the tumors again to radioactive iodine. And for that, and the reason why we are more and more mindful of not doing too much radioactive iodine is to minimize the side effects of radioactive iodine, especially if we can identify that it's not working anymore. And how do we classify radioactive iodine resistant tumors? These are tumors that never concentrated radioactive iodine, or that over time lost that ability to capture the radioactive iodine. We can see sometimes cases where some of the tumors in the lungs may capture radioactive iodine, but some might not. And if we also consider this classification, if we gave radioactive iodine, but despite giving radioactive iodine, we see that the tumors growing between 6 to 12 months after the treatment. And before we consider additional treatments, as I said, it's always important to look at the overall health. What are the other medical conditions? Trying to identify that we know where all the potential tumors are going, obviously keeping the patient's desires and goals and expectations. In this scenario where we start seeing concerns for resistance to radioactive iodine, it's important to try to find those cancer drivers that I was mentioning on the cells, and ensure that you have a multidisciplinary specialized team that can evaluate if it's the time to do something more. So when we have metastatic thyroid cancer, always the question is to try to identify, do we need to do any other surgeries? Is there a localized therapy like focal radiation that I need to do? Or if there's more rapidly progressing tumors, or tumors in a threatening location, we start thinking about using systemic therapy, or one of the oral treatments. And more at academic centers, there have been clinical trials, and some of us, in full disclosure, have done this redifferentiation therapy outside clinical trials. And there's going to be other lectures here that are probably going to dive into this much more deeper. But I wanted just to give you at least a brief overview, because this is something that we consider more and more. And actually, this study,
Dr. Salgado, just, I don't mean to interrupt, but we do only have 10 minutes left, and we do have 4 questions that have come in, and we might have some in the room. So I don't know how much further you want to go.
Okay, sounds good. I'm almost basically wrapping up.
Okay,
Basically,
perfect.
what I wanted to say is because with this approach, we utilize a systemic therapy or an oral chemotherapy to sensitize the tumors back to radioactive iodine. The clinical trials actually have prepared those patients with metastatic disease on the systemic therapy with thyrogen to be able to treat with radioactive iodine. And in my clinical practice, this has made much sense because if you're already on treatment with a chemotherapy agent that we know it needs to be on board for the redifferentiation to work, we don't want to add the symptoms of being off thyroid hormone therapy to the whole process to be able to identify which side effects are really coming from the chemo and give redifferentiation the best chance of success with the goal of seeing if we can then discontinue the oral chemotherapy afterwards. So with that, I want to go ahead and move forward with questions.
Okay, I'm going to take them a little bit out of order because I think it might make more sense. If you have some metastases already and
Mhm.
there's concern about those mets growing during the withdrawal process because your TSH is high for so long, is it perhaps safer to do the thyrogen instead?
So obviously each case is it's individual. In that scenario, I always like to first make sure that I know the actual size and location of the tumor. So in that scenario, I might consider doing an additional imaging to identify, is there an area that really is best suited to be treated with radioactive iodine, or do I need to do focal radiation first and then move forward afterwards with radioactive iodine and as I said, with careful consideration of steroids when needed. So that will depend on where those areas are. I do take a lot of care, especially if there's like spine mets, because I have had some patients that I actually have needed to treat first with what we call focal radiation or external beam radiation directly to that bone tumor before being able to do radioactive iodine for the remaining of the disease.
And then do you do it with thyrogen because it's safer for risk progression, for growth progression, or do you do withdrawal?
I have done it with withdrawal, but again, ideally, your physician would identify, based on how your labs are looking and how long after and the location, if the radioactive iodine by withdrawal is the safe way to go. But I do hope that after reviewing all this evidence that if your doctor is recommending Thyrogen, that you feel more comfortable proceeding that way.
Okay, I think might have a couple of quick ones. Is Thyrogen approved for children under the age of 18?
Um, so I do not treat pediatric patients. My understanding is there's still some data that would be needed. I think this question is a little bit better suited for a pediatric endocrinologist if they're using it off label.
And on the topic of off-label, we often hear about patients who are prescribed Thyrogen, but they're also asked to stop their thyroid hormone for a week or two. Is this typical?
I have seen that approach. To my knowledge, I haven't seen necessarily some data whether that provides any extra clinical benefit. I have seen circumstances where actually also somebody starts by withdrawal, and along the way they're having symptoms or they get blood work, and in the blood work, their TSH hasn't gone to the levels where we wanted, and so we end up adding then a thyrogen injection.
Okay. There is one particular person here whose shipment of iodine was lost in transit for a day, and their radioactive iodine was delayed by a day. Would that affect the efficacy of the treatment if they were using the thyrogen injections?
So, a little, so the thyrogen effect, it ends up being, it ends up having some short-term life. I guess it will depend on how quickly afterwards they administer the radioactive iodine. specifically also the dose. I think there might be some flexibility, but we really want to try to like avoid those delays if it's possible. Obviously, we're living in some times where a lot of things have been affected worldwide with distribution. So I would say, probably if it was given timely and there wasn't any quick drop on her on the person's TSH level, probably there might have not been necessarily a negative effect. But what I would do in that scenario, given the uncertainties, I would follow that patient a little bit more closely to make sure that we see the adequate response that we would have expected to radioactive iodine. And if we see that response is not exactly what we would want it before saying, oh, this is just resistant to radioactive iodine, I would certainly consider maybe a diagnostic whole body scan in the future.
So this question's a bit specific, but it might help others. This person had a recent total thyroidectomy with positive lymph nodes and 30-year-old male. And would you suggest Thyrogen or T4 withdrawal for best chances? He says he'd rather suffer a month of withdrawal to have even the slightest improvement of treatment. And he's also asking about how much RAI for his particular case, which is pretty specific. So I think maybe we'll just tackle the first half of that question and see if we have time for the second half.
Yeah, so I think with around 4 to 6 lymph nodes, again with the limited, and obviously this is always, do not take this necessarily as specific medical advice, obviously, because your doctor will definitely have more information than what we can do here. But it sounds like, based on the limited information that I have, it could be an intermediate risk case. So it's one of the scenarios where, in terms of dosing, I take into account with the postoperative thyroglobulin. In this scenario, I might also look at a post-op neck ultrasound, making sure there's really nothing left. And a lot of the times, as I said, this would be a lot of patients' preference. I think the data of using Thyrogen, we haven't seen an inferiority in the effectiveness. So I think if his clinical life and demands limit the being hypothyroid for some time, I would certainly feel very comfortable doing it with Thyrogen. But I've had some patients that actually do prefer to do the withdrawal, and if I find that there's no laboratory or physical health contraindication to do so, I would tell them, look, the data is pretty reassuring both ways, but obviously I take into account my patient's preferences.
Here's a quick one. How long after a Thyrogen injection is given would you see side effects?
Usually it should be quite soon. I would say those first few days. In reality, I don't see necessarily a lot of side effects in my clinical practice, but if it were to be a significant reaction, it would be something I would say quite certainly at the latest within the next 2 to 3 days after being administered the most. And for example, in the patients that are undergoing radioactive iodine, that are going to be treated with Thyrogen or withdrawal, and we feel that there's concerns for an area being transiently swollen, and we're going to do steroids. Usually you start with a higher dose of steroids a few days before you actually administer the radioactive iodine, or actually if you're going to do Thyrogen injections, you start the steroids at least 6 to 12 hours before the first Thyrogen injection, and then you taper that down either up until 2 to 3 days after the Thyrogen injections, or over a week. So usually when I do it, I try to taper it over a full week. I hope that gives some clarity to that question.
What is the benefit of having a Thyrogen stimulated PET scan and a whole body scan during the same time period?
So more and more Thyrogen stimulated studies have been considered, especially when there is still structural disease that you're trying to assess whether there is avidity of radioactive iodine or not. So trying to have those on the same time, it kind of tried to give you some clarity whether, especially if the physician has any concerns that there might be a mixed population of tumors, some that might be avid or not. The criteria for radioactive iodine resistance using the PET scan has been considered by some groups if what we call the SUVs, which is basically a number that tells us how bright tumors are on a PET scan. If we see that that number is very high, we tend to have concerns that that particular tumor is resistant to radioactive iodine, but that specific criteria has not been universally basically accepted. I do consider it in my clinical practice. In all honesty, I don't do a lot of thyrogen stimulated PET scans. I do, because of my oncology aspect of my practice, I do PET scans in my patients if I see, try to alternate modalities with CT scans, and if I see thyroglobulin levels being elevated. But in the very few scenarios, it has been very selected cases where we're thinking about radioactive iodine, as I said, versus not. And I can probably think definitely less than a handful of cases where I've used that approach in my years of practice, because usually I do have the answer of whether there's going to be some sensitivity to radioactive iodine through a different route.
Okay, I think that brings us to the end, actually over the end.
Good.
Thank you so much.
Thank you so much for everybody to have those wonderful questions. I'm very thankful to the organizing committee, to all my colleagues at the different institutions that I practice, and to my patients that have entrusted their care to my team for the last few years. And as somebody who actually lost a loved one many years ago to advanced thyroid cancer, I really appreciate organizations like ThyCa, and I'm honored to be part of the faculty today.
Thank you so much. Have a wonderful day.
You too.
You're getting a round of applause here. I don't know if you can hear it.
Thank you.